My name is Joshua Richter. I'm an associate professor of medicine at the Tisch Cancer Institute, Icahn School of Medicine at Mount Sinai in New York, and the director of myeloma at the Blavatnik Family Chelsea Medical Center at Mount Sinai. I'm really, really into myeloma, and just to put into context how crazy in myeloma I am, the average hematologist oncologist in the United States sees 0 to 10 cases of myeloma per year. I see 60 to 100 a week. I have an extremely busy myeloma and related disorders practice, really into first-in-human phase 1 and phase 2 clinical trials. My biggest interest is in bispecifics and trispecific antibodies in myeloma, because these are extremely effective off-the-shelf therapies that can be given anywhere. I'm a huge fan of them and really excited to have participated in a number of trials, including the recently approved Linvoseltamab based off of the Linker MM1 study. So the world of myeloma is extremely fast-paced. I just gave a talk this weekend, and my slides were 2 weeks old, and they were already out of date. So your assessment is spot on. I think the newly diagnosed realm of myeloma has been the story of the quad, where we recognize that the administration of a CD38 monoclonal antibody like daratumumab or isatuximab, along with a proteasome inhibitor, an immunomodulatory agent, and a steroid, is extraordinarily effective both in transplant eligible and transplant ineligible patients, with some of the more recent data from studies like IMROZ and Cepheus in the transplant ineligible patients showing median progression-free survivals of around 100 months, and some more recent readout for some of the transplant cohorts like Perseus and Griffin, giving us median progression-free survivals that are probably over a decade, absolutely changing the landscape and the outcomes for patients with myeloma. Now, in the relapse refractory world, what has really changed over the last several years has been the advent of T-cell redirection therapy with both bispecific antibodies and CAR T-cell therapy. And to put into context about how transformative this has been, if we look about a decade ago with all of our standard therapies in myeloma, like the immunomodulatory drugs and the monoclonal antibodies, they were all approved with single agent response rates in heavily relapsed patients of around 23 to 30%. Carfilzomib was approved at 23%, daratumumab at 29%. So that's really been the target. But bispecific antibodies having over a 70% response rate in this field and CAR Ts over 90%, were really transforming the way we manage relapse patients. And for many of them, we're actually extending survival beyond their actuarial survival, meaning many patients will no longer die of myeloma. Linvoseltamab or linvoseltamab was recently approved by the FDA for patients with relapsed and refractory multiple myeloma who've had at least 4 prior lines of therapy, including a CD38 monoclonal antibody, a proteasome inhibitor, and an immunomodulatory agent. Now, all of the bispecifics have been shown to be very efficacious here, but there's a couple areas where I think linvoseltamab may actually have an advantage. We recognize that step-up dosing can be done with bispecifics to mitigate the risk of side effects like CRS, which is cytokine release syndrome, or ICONS, the immune effector cell-associated neurotoxicity syndrome. For the other approved bispecifics, we often do this in the hospital over the course of 5 to 7 days. However, linvoseltamab was approved with a recommendation for two 24-hour admissions on cycle 1 day 1 and cycle 1 day 8. And personally, in my clinical practice, I'm planning to give prophylactic tocilizumab with that first step-up dose and not necessarily admitting the patient for the second 24-hour admission, meaning it's only a 24-hour admission one time. We've seen some amazing response rates. And in clinical practice, we recognize that in order to reduce infection rate and for better quality of life, we extend out the dosing with our bispecifics. But a lot of this has not been studied rigorously in clinical trial. However, in the Linker MM1 study, when we got to 24 weeks on linvoseltamab, patients who were treated at the 200 milligram dose who achieved the VGPR or better were transitioned to Q4 week dosing. And this is really amazing because it allows patients to have control of their disease with only having to come to clinic once a month. And we have robust data to justify that this is a fairly optimal way of doing things. So we recognize that despite the fact that I am absolutely myeloma crazy, the majority of myeloma in the United States is treated in the community. In fact, just around 80% of myeloma in the US is treated in the community. We've learned that in the relapse refractory world of myeloma, T cell direction is king. And there are many parts of this country that CAR T therapy may not be accessible, may not be appropriate, or may not be available. However, bispecific antibodies are entering the world of relapsed and refractory myeloma in a big way, and they're coming in many other cancers as well, with a fairly recent approval of a bispecific antibody in small cell lung cancer. I think there have been some reticence towards incorporating drugs like this into clinical practice because of the complex logistics involved in admitting patients to the hospital for extended periods of time. So I think if you have a relapsed refractory myeloma patient who's gone through at least 4 lines of therapy and may be eligible for a bispecific, but there's been some hesitancy about admitting them for extended periods of time, linvoseltamab allows us to provide this type of cutting edge treatment with minimal hospitalization. For people who are going to use linvoseltamab as their first foray into bispecific antibodies and specifically BCMA-based therapy in myeloma, one of the keys to success is appropriate prophylaxis. And the way we prevent against infections with these drugs is to provide HSV VZV prophylaxis with a drug like acyclovir or valacyclovir, PJP prophylaxis with either Bactrim, Mepron, or pentamidine. And all patients we recommend to receive primary prophylaxis with IVIG, as we recognize that hypogammaglobulinemia with all of the BCMA agents can lead to higher risk of infections that we can offset by providing IVIG prior to the onset of any infectious complications.